Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, cardio nerds. We pick up from last week as Dr. Richa Gupta leads a masterful discussion with Drs. JoAnn Lindenfeld and Javid Moslehi from Vanderbilt University and Dr. Enrico Ammirati from Niguarda Hospital in Milan, Italy. In episode 29, part 1, we learned about myocarditis in general, and now in part 2, we discuss myocarditis in the COVID era. We discuss the differential diagnosis for myocardial injury in patients with COVID-19, review 2 cases of presumed myocarditis in Milan, Italy, and the ramifications for heart transplant programs in the COVID era. Dr. Ammirati tells us the sobering reality of the toll this pandemic has had on healthcare workers and ends with an impassioned plea to learn as we move forward. As Dr. Ammirati so eloquently said, it is something that I hope will change the way we think about life, avoiding thinking that life can be dull when it is simply normal. Friends, be sure to tune in next week for episode 31 for a case discussion on myocarditis, when Dan, Corrine, Heather, and I lay the foundations for everything you need to know about myocarditis based on a real case. As always, just remember, this podcast is not meant to be used for medical advice. The views expressed here do not necessarily reflect the opinions or policies of our employers. The goal is simply to enjoy learning more about cardiology in the COVID era, directly from expert cardio nerds.
So I think we'll go ahead and move on. That was a good overview of the types of myocarditis, how we diagnose and treat fulminant myocarditis, and how our definition of myocarditis in the classical sense is really changing, based on these new molecular techniques that Dr. Moslehi was talking about. Let's switch gears now to talking about COVID-19 related myocardial manifestations and what we're calling myocarditis. Before we talk about myocarditis, I also wanted to just bring up the fact that there is myocardial injury in a substantial number of COVID patients. And myocarditis is just one manifestation of myocardial injury in COVID-19. For now, the way that I've digested the literature so far, it seems that we know 2 things. So first, troponin elevation in myocardial injury is a bad prognostic sign. And second, troponin seems to rise in conjunction with other inflammatory markers like IL-6, D-dimer, LDH, and this tends to happen in the later stages of illness based on some of the studies that we've seen coming out of Wuhan and China. So the running differential that I've come up with, which is really broad for why myocardial dysfunction may happen, includes myocarditis, as we've been discussing, sort of with direct myocyte infection, or an immune response to the virus, cytokine storm leading to an immune hyperinflammation that can be directly cytotoxic to the myocyte and result in endothelial dysfunction, Takotsubo or stress cardiomyopathy, or acute hypoxia resulting in cardiac injury from ARDS, along with acute pulmonary vasoconstriction and increased afterload on the RV with RV failure. So multiple different mechanisms. Anything I'm missing?
What we have seen is that there are an increased rate of complete atrioventricular blocks. So we do not know if this is related to a sort of myocarditis, but it's something that we observe in these patients that are COVID positive. At the end, we are not sure that it's just an association because now there is an epidemic, but this is a fact.
I see. That's really interesting. Can you tell us a little bit about your experience with these patients and what you're seeing in terms of cardiac manifestations and how you distinguish myocarditis from something else that might be going on with the heart?
First, patient presenting since the beginning with a primary cardiac condition. For instance, chest pain can be more easily recognized as patient with myocarditis associated with COVID. That in our experience, they have a recent history of fever and cough, but on CT scan or on chest X-ray do not have significant signs of pneumonia. So it seems that the pattern of clinical manifestation is slightly different, or there is a higher prevalence of cardiac involvement. These patients are rare comparing with patients with primarily lung manifestation. And then we have patients that throughout the hospitalization have an increase of troponin, and these patients are generally those critically ill patients. So we are not sure that troponin is a true manifestation of myocarditis, especially if on echocardiogram or on ECG you do not find any significant change. So it could be just a sort of response injury related to the hyperinflammatory state or related to the septic state. So in this case, in my view, it's not really a typical myocarditis. Even if they are very rare, we can have also acute myocardial infarction in patients with the COVID. So again, we are not sure that is related to the disease or it is just related to the very stressful situation in patients with an underlying condition of coronary artery disease.
That's really interesting. It's really wonderful to hear your personal experience. And I would just go back to one thing you said about mechanisms. I don't think you missed anything, Richa, but we also have to think about molecular mimicry, which is something we think we see in transplant with CMV, that you see more rejection following a CMV episode. And that's just a situation where a foreign antigen can share some sequences or some structural similarities to a self-antigen. And some of that potentially could explain some of the later presentations that we see. In other words, 8 to 10 days later. So that's one other possibility.
I have to add that we had also other coronavirus subtypes, and in the last 2 years we have performed nasopharyngeal swabs in all patients presenting with acute myocarditis, and the coronavirus and influenza virus were the most common virus associated with acute myocarditis. That means that a molecular mimicry can be a relevant mechanism of myocardial injury, because at the end, in previous cases, we have no trace of RNA virus in the myocardium when we perform endomyocardial biopsy. So in my view, the molecular mimicrism can be a phenomenon that is also present in COVID.
And just for our listeners, can you just explain a little bit more by the molecular mimicry? You're referring to sort of this more like a reaction to an immune reaction to the virus rather than direct infection of the virus itself. Is that what you're referring to?
Yes, there may be cross-reactivity with an antigen on the virus that's similar to a self-antigen, and thus you make antibodies to self.
Got it. And it sounds like this process may happen more chronically as well. And be much more of a prolonged state of pathology for the patient, extending past just the acute infection and maybe even lead to chronic cardiomyopathy. Is that what we think?
I don't know that we know that, but at least it could lead to the late You could say that a patient who's been having symptoms for 8 to 10 days, if they develop antibodies at that point, and there are certainly other reasons to develop those, but that could then present against antimyocardial antibodies or others. So that would explain some of the late. Whether or not that would go out chronically, we don't know.
Yeah, I fully agree. Also, in my view, the point is that it can explain the acute manifestation from the onset of fever or pharyngitis to the onset of acute myocarditis. But as in most of cases, myocarditis resolves spontaneously. That's probably the possible explanation, is that immune response respond against the virus, so there is no more viral infection, and for this reason there is also a feedback, and also myocarditis can resolve spontaneously. We do not have enough evidence that a persistence of virus, at least in humans, can cause cardiomyopathy, in my view.
Thank you, Dr. Ammirati. Actually, I'm going to be starting in the CCU in 2 days at the time of this recording. And so I really do want to make sure I understood your methods of differentiating, at least your clinical way of differentiating whether cardiac injury in the setting of COVID is truly myocarditis or not. And if I heard correctly, I heard that you used 2 differentiating features. The first one was whether cardiac injury was the predominant feature of the initial presentation, where myocarditis might be more likely, versus cardiac injury developing later in the course of a complicated illness. And the second point you made was looking at the biomarker elevation troponin elevation if it's associated with EKG changes and LV dysfunction as opposed to an isolated troponin elevation where the latter may be from demand ischemia or inflammatory injury. Is that fair?
Yeah, it's fair. We have some cases of true Takotsubo syndrome, but this is again the case of sick patients that with a very stressful condition, and in most cases were aged women. So again, it occurred in patients where Takotsubo can be expected at the end.
Just another, let me take this advantage to ask Dr. Ammirati a question. Have you seen much elevation in wedge pressure, do you think, in these patients? And just all of them with underlying cardiovascular comorbidities, you might expect in the absence of a myocarditis that they might be stressed and have elevated wedge pressures. And with damaged lungs, the level of wedge pressure you need to have a lot of fluid would not be as much. Have you seen that at all in your subjects?
I'm afraid that we do not use pulmonary catheterization because at present we have more than 50 beds of intensive care units, all full, and we do not generally use pulmonary catheterization in these patients. Another point is that in most cases, as we have a dramatic lung injury, and there are also risks related to barotrauma, I'm not sure that it's really a safe maneuver in cases with high pulmonary hypertension in this condition to perform this kind of maneuver. I don't know, because I have no personal experience in pulmonary catheterization in this setting.
Yeah, we don't either. Just we've noticed a couple of cases that responded whose oxygen saturations improved remarkably with some diuresis. They were clinically suspected to have that. And I don't know either, but it'll be interesting to see because we know damaged lungs leak a lot more at a lower wedge pressure than undamaged lungs.
But
so
I'm
it'll
sure,
be interesting.
Yes, I'm sure that diuretics can be useful as we see that there is also a significant increase in proBNP levels. And that for this reason, at least we have an indirect marker of increased wedge pressure. So I believe that it's reasonable that the diuretics can be useful in this setting, in particular if we see an increase of proBNP.
Well, we hope, this is just an aside, but we have a little venous wave monitor that sits on the wrist, and we have a very good data that it mimics wedge pressure. So we are going to start using that in our patients to see if we can see what the incidence of an elevated wedge pressure is in a non-invasive way without having to have people go in the room any more than they would otherwise do. So hopefully we'll get some data from that study sometime soon.
And I'll just jump in here for a quick question relating to the idea that we can't really use PA catheters even though we may want to. Are we having similar issues with endomyocardial biopsy? Are we doing bedside biopsies, or is that going to be a problem going forward?
I have to say that I do not like to perform echo-guided biopsy, but this is due to I'm used to perform fluoroscopy-guided biopsy. But we are in the setting, at least in Milano, where there is a real outbreak, and so it's very difficult to organize an endomyocardial biopsy. So we base our diagnosis on clinical, echocardiographic, and laboratory markers for the suspected diagnosis of myocarditis. Of course, if we have significant, for instance, ST elevation, of course, we perform a coronary angiography, but as these patients are critically ill in most of cases, due to a lung disease, we do not want to perform an endomyocardial biopsy to add a risk related to this maneuver, as we feel that the main cause of disease is the pneumonia. We do not have at present patient on venous arterial ECMO, and all patients that need ECMO are on venous ECMO. So it's not such a relevant issue that can change really the therapy as in other kind of myocarditis where we think that maybe it's a giant cell myocarditis or an eosinophilic myocarditis.
Right. We agree. We can't find a reason in the face of a positive test for COVID-19 that we can't find a way to biopsy those people routinely, so we're not doing it.
Even if I believe that it's very important to do that. Probably we hope in the next weeks when the situation will be under control with less cases, maybe we will be able to better characterize each patient if there are complications like that.
Agreed.
Yeah, it makes sense. I think we sort of, on the other side, we've not had a lot of experience with these patients yet, that we're sort of underappreciating how logistically challenging it would be to float a swan in a patient with ARDS who may need proning, for instance, or to do an invasive procedure like a biopsy on someone who's, on the vent or cannulated with VV ECMO. You mentioned that we sort of know the prognosis of lymphocytic myocarditis. I wanted to ask you, Dr. Ammirati, in dealing with these COVID-19 myocarditis patients, it seems, at least in case reports, that their prognosis overall is good and these patients recover. Has that been also consistent with your experience?
At present, we have in my hospital, at the Niguarda Hospital, we have other 2 cases of clinically suspected acute myocarditis. One is a 38-year-old patient and the other one is a child. In the first case, ejection fraction is preserved. There is almost no pneumonia, but this patient is COVID positive, and we perform a coronary angiography, and the clinical, it was an uncomplicated myocarditis. The second one is a child that is in the ward with left ventricle ejection fraction of 30%. We decided to use steroids, but in this case, I believe that also intravenous immunoglobulins can be an alternative, or the use of both of them. And again, we do not perform a cardiac magnetic resonance even in this setting, because cardiac magnetic resonance is currently closed, because you have to understand that it's also very difficult to move these patients because they are contagious, and so cardiac magnetic resonance is closed.
And that's the same case at Vanderbilt too.
Yeah. And at the end, the prognosis is not so bad. But we have also cases reported from other hospitals that they told me with fulminant presentation. So if you have a fulminant myocarditis associated with the COVID, can be a big problem. But in most of cases, we haven't seen such a dramatic lung injury like in cases the mainly pneumonia. So I don't know if this the immune response is different, is more directed against the heart. I don't know why these patients have myocarditis while the lung manifestations are not so bad. So I cannot say that patients with myocarditis have a worse prognosis. We can say that patients with cardiac injury are associated with a worse prognosis.
I see. So it does seem like there's almost a dichotomy to the presentations.
Probably it's not just a dichotomy, because you can have also gastrointestinal manifestation, like in children, or you can have, even if they are quite rare, neurological manifestation. So it's really a systemic disorder where pneumonia, interstitial pneumonia, is the most common manifestation.
Okay. One last question about whether you use inflammatory markers as any sort of guideline for therapy, or whether you're checking these routinely or in any systematic way, or maybe only in the critically ill patients. How are you using those?
I believe that are very important, and to have an idea since the beginning, since emergency department. So C-reactive protein, procalcitonin, and whole blood count with a lymphocyte count, D-dimer, and even troponin, LDH, transaminase, renal function are very important to have a general idea of the severity of the disease. Oxygen saturation is not enough in my view, because it's very variable from young subject to older subject. And we have seen that this marker since the beginning are associated to increased risk, in particular D-dimer. There is a Lancet paper where D-dimer above 1 are associated with a nod ratio for mortality of 18, so very high. We are using tocilizumab. We have a national prospective trial. It's not a randomized trial with use of these anti-interleukin 6 inhibitors. And what we have seen is that C-reactive protein and interleukin 6 levels can really decrease, and this is associated with a significant improvement in the clinical condition of patients. So it seems that the inflammatory response, the so-called cytokine storm, is really relevant. And so I believe that the model that describes in 2 phases, in 2 stages, from the viral infection to the inflammatory response, is a good model to describe the disease and to think on how to cope with the disease, thinking at different targets at different time points. So probably at the beginning, even before fever or during the fever phase, drugs that reduce the viral spread in the lungs are more important, while during the late phase of fever or during the lung injuries, where you have evidence of high level of inflammatory markers, it is more important to reduce the inflammatory response. So I believe in this model, and we look also at D-dimer, and we are all patients are on enoxaparin, at least prophylactic, and we are thinking about a trial where we compare prophylactic enoxaparin to half dosage of anticoagulation with enoxaparin.
That's really interesting. So it's interesting to hear that your experience is supporting that model of first the virus being the initial predominant cause of pathology, followed by the immune response of the host playing a bigger role later on.
With regards to the anticoagulation, and obviously the D-dimer is elevated, and we initially heard about this from our colleagues in China, are we seeing a lot of extra clots that are associated with that D-dimer, or is it just we are going after the lab with the presumption of the coagulation cascade is just out of control?
Of course, the D-dimer can be also a marker of inflammation, so it could be increased due to the inflammatory response. In most of cases, we do not have evidence of signs of thrombosis, venous thrombosis, even if in at least some we perform just a few post-mortem examination, and this is a real pity, as we do not know the causes, in particular of sudden cardiac death. So we are not sure that in some cases they are caused by pulmonary embolism, for instance, or if there are microembolic events in the lung, because one potential cause is that beyond the pneumonia, it could happen microthrombotic events in the lungs that can explain such the severe hypoxia that is seen in this patient, and could explain the fact that even on mechanical ventilation you are not always able to increase oxygenation. It's a complex issue. We do not have a clear response at present, but I believe that it's time for clinical trial to assess if an hypothesis is real or not. It's something that we missed at the beginning of this outbreak, at least in Italy, but we hope that everywhere there will be a phase where clinical trial can address some clinical issues.
So I wanted to spend the last few minutes of the episode to discuss the implications of COVID-19 on heart transplantation. And Dr. Ammirati, you wear many hats. You're a transplant cardiologist as well. I wanted to know a little bit about how you all have had to deal with heart transplantation in the era of COVID-19 and how you've managed patients that are on the wait list and who need to be transplanted? What's been happening?
During these stressful days, we were able to keep on the transplant program, and we performed 3 transplants in March, but it was very challenging. I don't know if it's right to keep on performing transplant in this setting, because you know that probably patients that are transplanted in this setting are at higher risk to be infected by this virus, even if you try to isolate these patients. For this reason, we decided just to perform transplant in patients in urgent status, so just in patients that were already admitted in the hospital, dependent on inotropes, or patients on LVAD with severe infections, or patient with acute disease. For instance, we had a 51-year-old patient that was on VA ECMO due to an acute myocardial infarction. And I believe that is the right way to approach the problem. You keep on the program, but just for urgent transplant, because in my view, if a patient is quite stable at home, probably is reasonable to delay the time for transplant.
That makes sense. So just sort of restrict the transplants that you do to the patients that most urgently need it, as a way to prioritize them. I also wanted to ask you and Dr. Lindenfeld, sort of what are we doing now in terms of selecting donors? How is that process different? Are we testing everybody for COVID-19?
So far, I think we are testing all donors. We're testing all recipients too, as well, for COVID-19.
Yeah, the same in Milan, of course.
And then, do you know any transplant patients who have gotten infected? Either of you, maybe we start with Dr. Ammirati. How have they been doing? There have been case reports that because they're better at practicing social distancing, that they seem to be doing okay as a whole. But these are just case series. What do you think?
It's different when we consider a recent heart transplant, and all heart transplant we performed in the last month are negative. So we check for nasopharyngeal swab, and they are at present are negative. Then we have transplanted patients that are at home and they live their normal life. And based on our knowledge at present, we know that at least 4 patients that receive an heart transplant got the infection. We know that 1 patient died. We do not know exactly the course during his hospitalization. And we have 2 patients that survive without big issues. Just they reduce the level of mycophenolate, while we had another heart and kidney patient that is still admitted with severe respiratory distress and insufficiency on non-invasive ventilation at the beginning of hospitalization. And in that case, we treated this patient with tocilizumab, and now is just on oxygen. So he improved, and this is an example that we add over the maintenance immunosuppression with cyclosporin, mycophenolate, and prednisone, also tocilizumab. Of course, there is an increased risk of infection, but we still believe that can be useful. You have to think that at the beginning, this patient had the level of C-reactive protein of 100 with an upper reference limit of 0.5, and the procalcitonin was negative. So you have a marked inflammatory response associated with this infection, and there was a significant improvement after administration of the tocilizumab. So I really believe that trials are needed to demonstrate that this strategy can be effective. Maybe not anti-interleukin 6, anti-interleukin 1, but I believe that it must be tested.
Yeah, that makes sense. And it sounds like we also just need bigger series to know whether heart transplant patients do worse or better, or are just like anyone else who get the infection, that they have the same sort of spectrum of severity, I think.
I believe that is still based on age, on presence of significant comorbidities, for instance, renal insufficiency, or a recent history of infections, or left ventricle dysfunction, and again related to the sex, as we have seen that male patients have a worse prognosis comparing with women. For instance, in Italy, we had this sad fact that several physicians died. Currently, more than 87 physicians died, and most of them are men. So we are not, but the proportion till a few days ago, we had 56 male physicians comparing with 3 female physicians that died. Now I do not know the current proportion, but this is just to have a general idea about the proportion, the difference between women and men. And another important risk factor that we have seen is related to obesity. Obese patients have by far a worse prognosis. So all these factors must be considered also in our transplanted patients.
Wow, that discrepancy between men and women is really profound, and that is really very, very sad. I'm really sorry to hear that about those deaths. I had one last question really for Dr. Lindenfeld, which is sort of how we're changing things at Vanderbilt in terms of our transplant program. We've been traditionally, very high volume and able to get patients transplants who really need it. What's going to be different? Do you see us doing a lot more LVADs? What are you thinking is on the horizon?
Well, I think this is a difficult decision because we have to pay attention to a number of factors, and that includes the hospital, ability of both the donor hospital and the recipient hospital to have adequate resources, protective equipment to do these so that we're not preventing routine patients with COVID-19 being treated. And then we also have to worry about the risk of the patient getting it. If they're already hospitalized and have a very high risk for death, then we have proceeded ahead. One thing we have done, though, is we've changed remarkably our donor procedures in that we have the local hospital procure the organ, and we send only one person to pick it up and bring it back. So that's changed a lot. And this really, the patients in the hospital, they're already at risk for being in the hospital, for higher risk for getting this virus. So we feel better about their risk if we've checked the donor and other things, and we have adequate resources. So I think a lot of things will change overall. And just before we end, I just want to thank Dr. Ammirati for sharing his incredible experience and what's been done in Italy. And we're so sorry about the people lost, everyone, including the physicians and everyone else. And we just want to thank you for taking the time today to educate us.
Thank you. It's very important to share experience because I believe that probably we did not take care enough about the Chinese experience. And that was a big mistake, at least at the beginning, because probably there were important manuscripts published in Lancet, and just reading these initial reports, you really could understand the severity of the disease. And so I really believe that we missed these pieces of information that is related to the fact that we are not really in contact with other realities. We are more oriented, and we share more experience between Europe and US probably than comparing with China. And this is probably also an occasion to grow up together, I hope.
I think that's a great message. We really have to learn from each other and sort of rely on each other, and everyone else's experience should guide us in a situation like this. So thank you for sharing your expertise with us today. This has been incredible information.
Thank you so much.
Thank you, everyone.
Thank you.
Well, that brings us to the end of our show, so it's time to make like an S2 and split. You can follow us on Twitter at CardioNerds. And please share what made your heart flutter this week. Send us a clip to cardionerds@gmail.com. If you enjoyed the show, be a nerd and spread the word. And now, a flutter moment.
Hi, Cardio Nerds. My name is Barry Stanton, and I've been a nurse at the Cleveland Clinic for 30 years. I have a 2-to-1 flutter moment. My first flutter is that I've been so blessed and honored to work with the smartest, most compassionate, and innovative cardio nerds in the coronary intensive care unit. My second flutter is that I've been able to offer them a little comfort and happiness by making masks during COVID-19. I've made about 250 masks out of my quilting material for my coworkers, friends, and family. I love you, cardio nerds. Keep teaching us and stay safe. Thanks for the show.